It is useful to remember that there are many countries outside regulated markets where the Orange Book is not used. So in such jurisdictions, the pharmacists are not legally allowed to substitute drugs because there is difference in those markets among the generic drugs. Okay, so the reason being that there are differences in the way those drugs are formulated, because the formulation factors, like say factors like particle size, or maybe the rate of disintegration or dissolution might be different. Okay? Or maybe the excipients are different excipients. Okay, so what are excipients? So the dose, we've got the drug, and the drug is made into a dosage form. Okay, and this dosage form is made up of the API, which is the active pharmaceutical ingredient, and excipients. Okay, so excipients lack the pharmacological action, but they are required to make the dosage form. Okay, so there are different excipients like diluents, binding agents, disintegrating, disintegrants, etc. So those excipients may vary from manufacturer to manufacturer. And if it's a tablet, for tablets, the compression force. Okay, that is used to compress the granules to form the tablet, that might be different. So these factors are usually responsible for the different pharmaceutically equivalent drugs having different bioavailability. Okay, so that it's useful to have that in mind. But for a regulated market like the US, that's not an issue because the Orange Book is used. Okay. There is one more point that I would like us to remember before we go into further discussion. That is, when we talked about the dosage form, we talked about the oral preparations here. We also need to remember that bioavailability for other dosage forms is, shall we write it somewhere here? Yeah, I think we can write it here. So parenteral dosage form have greater bioavailability than oral forms, and in turn the oral forms have got greater bioavailability than the rectally administered dosage forms, and rectal dosage forms have greater bioavailability than topical dosage forms. Okay. So that's something that we missed to discuss. That, yeah, for the sake of completion, we need to remember that point too. Okay. before we go into the next factor that influences bioavailability. Okay, so the next factor that we're going to discuss is the factor related to GIT. Okay, so let's bring it up somewhere here. Then we can talk about factors related to GIT which influences bioavailability. So, if there is increased surface area, that increases bioavailability, and we talked about this when we talked why even ionized drugs get absorbed in the intestine, okay, because intestine has got a greater surface area. The next factor which is related to the GIT is the increased blood flow. Okay, so if the blood flow to the GIT is somehow disrupted, maybe due to surgery, then bioavailability decreases. Okay, so patients who undergo surgery, before undergoing surgery, they are not given anything per oral. Okay, NPO, again, nil per oral. Okay, so they are not given food because there might be disruption to the blood flow as well as the nerves supplying the GIT might be depressed. As a result, the food could kind of interfere. Okay, it can lead to compaction, and then those compacted food can lead to other complications. Then there is favorable pH. Okay, so some drugs are absorbed from the stomach, some are absorbed from the intestine, and if there are changes in the pH, then according to our previous discussion, it might interfere with the absorption. Increased gastric emptying. Okay, so cholinergic drugs can increase gastric emptying, or there can be some physiological conditions which may increase gastric emptying, which might decrease the gastric transit time, and that might interfere with bioavailability. So these would be the factors that increase bioavailability. Okay, so these are factors increasing bioavailability. Yes, so there can be factors that decrease bioavailability. Okay. And what could be the factors that decrease bioavailability? It would be opposite to all this. Okay, so decreased surface area, decreased blood flow, unfavorable pH, and sometimes drug intake concurrently with food. Okay, so if in some cases, if the drug is taken with food, it might decrease bioavailability. There can be food-drug interactions is what we mean. But when we say that, we need to remember that certain drugs some drugs like say griseofulvin, which is an antifungal drug. This drug has got increased bioavailability if it is consumed with fatty foods. Okay? Then there is this another common example would be the antibiotic cefuroxime. Okay, so this drug also there is increased bioavailability when it's consumed along with food. And then there is this antiviral drug. Okay? Saquinavir. Okay, so this drug, again, these are examples of drugs that the bioavailability increases, so there is increased bioavailability when consumed with food. Okay, and what are the examples? These drugs. Okay, so, but in general, drug intake concurrently with food decreases bioavailability. But as in science, there are always exceptions, and these are the exceptions. And what could be the other reason that could influence bioavailability of drugs from the GIT? Yes, the presence of diseases. Okay, so the diseases of the GIT. Okay, diseases or surgical corrections of the GIT can also decrease bioavailability. Okay. And anything that interferes with the blood flow. Okay, and what could be one of the diseases that affects blood flow systemically? Yes, it could be congestive cardiac failure. Okay. Okay. So anything that decreases, that interferes with the blood flow can reduce bioavailability. Yeah, so surgical correction or diseases of the GIT can interfere. So those would be the most important factors which are related to GIT. Okay. The next factor influencing bioavailability is presystemic elimination. Sorry, there was an omission here. It's presystemic elimination. Okay, so we're now going to look at the factors that influence presystemic elimination. Let's take it down somewhere there. Okay, so what is presystemic elimination? So let's write it down. Okay, so this is also known as first-pass metabolism. Okay. So it basically means the elimination of the drug. Let's write it down here. Elimination of the drug during the passage from the site of administration to the systemic circulation. Okay, so assume we give a drug to a patient and orally, and the patient takes the drug and it gets it reaches the GIT. So in the local environment of the GIT, it might undergo some changes, and then it gets absorbed into the blood vessels or the lymphatic system, and in those areas it may undergo changes which results in the quantum of the drug administered not reaching the systemic circulation. Okay, so those processes that do that, they are called first-pass metabolism. And this concept would hopefully become clear when we look at some examples. Okay. So let's say a peptide drug. Okay. What could be an example of a peptide drug? It could be, say, insulin. Okay. And imagine we are giving this insulin per oral. Okay, we are administering insulin orally. So what would happen is this insulin would get metabolized in the GIT because there are proteases. Okay, so in the intestine there are proteases, and these proteases would degrade insulin, okay, to amino acids. Now, for the insulin to act, the structure of the insulin, which is a dipeptide, as you might know, as we know, it's a dipeptide. Okay. So this structure needs to be intact for it to have its action. Now, if we give it orally, the proteases would degrade the insulin into amino acids, and those amino acids don't have this structure when they are absorbed. Okay, and so these amino acids would be absorbed, but they lack this particular structure, and because they lack this particular structure, it wouldn't be able to decrease blood sugar level. Okay. Yeah, so this is an example of first-pass metabolism. Okay. So in general, what we're going to summarize here and say is that peptides are metabolized in the lumen of the GIT. And therefore, they won't have the desired bioavailability. Okay. So, and we would give an example here. We talked about insulin. So the example would be insulin or another drug like, say, oxytocin. Okay. And what is the metabolic enzyme that could bring about degradation? It would be the peptidase enzymes. So that is the presystemic elimination. So if we give these things orally, there could be presystemic elimination. So what do? Yes, we administer insulin and these drugs like this subcutaneously. We administer these drugs subcutaneously to prevent presystemic elimination and thereby decrease bioavailability. Okay. So if we want to increase availability of drugs, peptide drugs like insulin or oxytocin, because of this problem, we cannot give it orally. And so what do we do instead? We administer such drugs subcutaneously. So the question is, if someone asks us why is insulin given subcutaneously, then the answer is that if we give it orally, it would be degraded. To increase bioavailability, we give it subcutaneously. Okay, so if we give subcutaneously, in the subcutaneous environment, there is no peptidase enzyme. Okay, and therefore it will have systemic effects. Okay. Okay, there are other drugs which are having the same problem, like drugs like catecholamines. Okay. So catecholamines example would be adrenaline. So if a drug like adrenaline is given, say adrenaline, if a drug like adrenaline is given, there are certain enzymes in the gut wall if we are giving adrenaline orally. Okay, so if we give adrenaline orally, it's a catecholamine. Okay, because it's got the catechol nucleus. So what's a catechol nucleus? Okay, so that's a catechol group. So therefore it's called a catecholamine. So if a catecholamine like adrenaline is given, adrenaline is also called epinephrine. Okay, so if adrenaline is given orally, what's going to happen? There are certain enzymes in the walls of the GIT. And what's the most important enzyme in the gut wall? It is catechol O-methyl transferase. Okay, so this is abbreviated COMT. Okay, so if adrenaline is given orally, in the walls of the GIT there is this enzyme COMT which will degrade, and this COMT, what does it do? It degrades catecholamines. Okay, so as a result, adrenaline won't have bioavailability if it is administered orally. So what do? We give it parenterally. Okay, so this is the second example here. Okay, the second example of presystemic elimination. Okay, and the strategy is we give it parenterally. Okay. Now, the point to remember here is that whenever a drug, say, let's draw like that, okay, so roughly representing the stomach and the intestine. So if it is, if a drug is given and it is absorbed, it will be absorbed into the blood vessels or the lymphatic system, and then these blood vessels usually take it to the liver. Okay. And this liver has got lots of enzymes that will chemically modify whatever is absorbed. Then it will release the metabolized drugs into the systemic circulation. Or what the liver does is it metabolizes it and then eliminates it into the bile. Okay, and through the bile it will be transferred back into the intestine. Okay, So we need to remember that this is what is happening. So whatever is absorbed goes into the liver mostly, and that is called um, the splanchnic circulation takes it to the liver, and then there is metabolism. Okay, and then it comes into this systemic circulation. So this process is called first pass metabolism. Okay, first pass metabolism. Okay, so we need to remember what is first pass metabolism. Okay, so why is this important? It is important because some drugs are completely metabolized. Some drugs are completely metabolized by the liver during first pass metabolism. Okay, and do we have examples of drugs which are completely metabolized by the liver during first pass metabolism? Yes, there are drugs like lidocaine, okay, the local anesthetic lidocaine, and the two examples that we cited previously, insulin and oxytocin. Okay, so these drugs are almost completely metabolized by the liver, okay, and presystemically. Okay. So, yeah, so what's the option here? We can give these drugs parenterally. Okay. So we need to remember that insulin can be degraded by the proteases which are present in the intestine. But if that digestion is not complete, it might get absorbed into the systemic circulation. But when it gets into the systemic supply, it goes into the liver. There again, it can get degraded during this process. Okay, because some proteases are also present during its travel. Okay. All right. So the thing to remember here is drugs like lidocaine, they are completely metabolized in the liver, whereas these drugs mostly they are degraded within the intestine. Okay, but then, yeah. So the point to remember here is that some drugs are completely metabolized by the liver during the first pass metabolism. So the option would be to give it parenterally. Okay. So what we have learned here is what is first pass metabolism, and it is important for the drugs which are metabolized by the liver, and we have cited the most important example here. But we also need to remember that some drugs, though it may be digested in the intestine, it might not be completely digested. It might be partially digested. Okay, so yeah, so that is why we have cited these two examples. Okay, but remember, these drugs are mostly degraded in the intestine itself. Okay. So if we think about it, what's the other option? So we said some part of it gets degraded in the first pass metabolism. So what can we do? We can increase the dose, right? So if we increase the dose, a part of it would be eliminated, but the required therapeutic dose can still be available or in the systemic supply. Okay. So this can be overcome. So drugs where the major part is metabolized in the liver, one strategy could be to increase the dose. Okay. So what's the other strategy? The other strategy is another strategy is to use a different route. Okay, where the initial problem is reduced. Okay, so that is what is being done. So now we understand the logic behind why it's done. Okay, and then there are drugs like say nitroglycerin. Okay. And this is a vasodilator drug. Now this nitroglycerin, if it is given per oral, it will undergo first pass metabolism. And bioavailability will be less. There will be decreased bioavailability due to first pass metabolism. And for it to undergo first pass metabolism and get into the systemic supply, it takes time. Okay, there is time gap to reach systemic circulation. Okay, so why is this drug given? Right, it's given whenever there is compromise to blood flowing into the myocardium. Okay, so that is a serious condition, and we need to immediately vasodilate the blood vessels so that the myocardium does not have prolonged ischemia, which may lead to necrosis. Okay, and that can lead to cardiac failure. Okay, so this drug needs to be systemically available immediately, and as far as possible, it should not undergo first pass metabolism. So what's the strategy that is used for nitroglycerin? Because of this presystemic metabolism, yes, it is administered sublingually. Okay, so if it is administered what is sublingually? Lingua means tongue. Okay, sub means under, so under the tongue. Okay, so under the tongue, if we look, that's the tongue. If we look, it's red in color under the tongue in a normal person. And why is it red? Because there is ample blood supply. Ample blood supply, the mucosa is thin. Okay. So if the drug is sufficiently lipid soluble and we place it under the tongue, it will dissolve and it will get absorbed into these blood vessels, and these blood vessels directly reach the systemic circulation. Meaning it bypasses the liver. Okay, it directly goes into the systemic circulation, and therefore it becomes more bioavailable. Okay, so what is a bypass? Okay, so I think an analogy is in order. So usually highways, okay, highways usually connect capitals. Okay, so this is capital A, and that might be a capital B of some state, and the connection is called a highway. And usually this passes through urban areas. Okay, and if suppose there is our destination is a place C. Okay, we need to go from A to C. And so we got an option of going through B and then going to C. Okay, or we take a route that directly reaches C without touching B. Then we say this is a bypass. Okay. All right. So yeah. So here we are bypassing the liver. This is not a very good analogy, but anyway, I hope you get the point. Okay. So if we give it sublingually, it bypasses the liver and it directly enters into the systemic circulation. All right. So that is another example. Okay. Yeah, so remember we talked about a strategy that we could increase the dose, right? So do we have examples for that? We certainly do. Okay? So there are drugs like morphine, propranolol, not used nowadays much, but for historical importance, propranolol. Let's not write it. Let's write something that's used clinically. Say, nifedipine, methyl testosterone. Okay. So these drugs, they undergo first pass metabolism. Okay. They do undergo first pass metabolism. So the strategy that is used is to increase the dose. So the oral dose, so in these drugs the orally administered dose is greater than the parenteral dose. Okay, oral dose is greater than the parenteral dose. Why? Because that is a strategy. And why is the oral dose greater than the parenteral dose? Because these drugs undergo first pass metabolism. Okay, so that answers another question, why the oral dose of these drugs are greater than the parenteral dose, because we kind of take into consideration that it is definitely going to undergo first pass metabolism. And even if it undergoes first pass metabolism, the logic is that if we give an increased dose, the required therapeutic dose would reach the systemic circulation. Okay, so we are kind of sacrificing a part of it. Okay, for first pass metabolism. All right. So we have got two examples of the two strategies that is used because of first pass metabolism. Okay. All right. Okay. Drug interactions. Drug interactions can modify bioavailability. Do we have examples? We certainly do. Okay, antacids. So what are antacids? Right, they're given for hyperacidity or acidity in general. Okay, so they're basically calcium or magnesium salts. So divalent ions usually. Okay, calcium or magnesium salts. Okay, so the most common antacids are calcium or magnesium salts. So the problem is these salts can form complexes. These salts form complexes with drugs such as tetracycline. Okay, tetracycline and maybe iron preparations also can get they can get complexed. Okay, so the most important example of a drug interaction that modifies bioavailability is administering calcium or magnesium salts concurrently with tetracycline. So what happens is tetracycline forms this chelating complexes with chelated complexes with calcium or magnesium ions, and then that complex is not absorbed. Okay, so if you are giving tetracycline for systemic effects, for say for acne, okay, so the aim is that tetracycline gets into the systemic circulation, and then it acts against the causative agent of acne. What's the causative agent of acne? The bacteria that is usually implicated in acne. Right. Okay, so you know. Okay, so the idea is you give tetracycline, and this tetracycline enters into the systemic supply, and then it kind of kills this bacteria. So that's the reason why you're giving tetracycline. But if you administer it with antacids, what's going to happen? Tetracyclines complexes with these salts, and it is not absorbed. If it's not absorbed, what happens? It doesn't get into systemic supply, and if it doesn't get into systemic supply, it does not have its therapeutic property. Okay, so there is therapeutic failure. Okay, so that the consequence can be therapeutic failure. Okay, so there are these drug interactions which can modify bioavailability. Okay, but it has also got a positive aspect. Okay, for example, vitamin C, if it is given with iron salts. Okay, so where do you supplement iron? Maybe in a pregnant woman. Okay, so you want the woman to have increased iron. So if you concurrently administer it with vitamin C, then the bioavailability increases. Okay, so there are positive drug interactions. Okay, so this is an example of a negative one, and there is a positive drug interaction where there is increased bioavailability of iron salts when concurrently administered with vitamin C. But the point is, drug interactions can modify bioavailability, and it can be in a positive aspect or a negative aspect. All right? Okay, so those are examples of drug interactions which can modify bioavailability. Okay, so there are lots of other examples. But it is useful to remember these examples along with those. Okay, so with that, we will wrap up this lecture, which was looking at the factors influencing bioavailability. Okay, so in this lecture, we have covered the most important factors which influence bioavailability. Okay, we said that the factors influencing bioavailability are related to the drug. We talked about that, and we said that it's related to the dosage form. We discussed that, and we have seen what are the factors related to GIT which influence bioavailability. We have seen how presystemic elimination influences bioavailability, and we have seen some examples of drug interactions which influence bioavailability. So thank you for your attention.